Hello, everyone. I'm Dr. Diana Bitner, and I'm so excited that you've joined us tonight to talk about, let's chat about women's health with these nationally acclaimed experts. I've met all of these colleagues at national meetings where I went out from West Michigan to learn about women's health and how to provide specialized care to women. What we all have in common is that we really care that women get personalized health care from each of us, from our own expertise. We've seen gaps in women's health care, and we've worked tirelessly to fill those gaps. So I'm very excited to talk to you tonight about personalized women's health care. Each of us are going to talk about why we do what we do and give you some takeaway tips about maybe a specialized area of focus. We want to keep this comfortable and casual. I look forward to seeing what's going to happen. But please feel free to put in your questions on the sidebar of either Facebook Live or YouTube, and we'll do our best. If you have questions after the fact, we'll also do our best to answer those, after the fact. I really do challenge the healthcare providers who are watching tonight, and I challenge the women who are watching tonight to think about healthcare in a more broad manner. I started True Women's Health because I wanted to provide our patients more time and to go deeper into what they really care about. So to introduce my colleagues, Dr. James Simon, I met him first at a national meeting and listening to a debate about hormone replacement therapy, learned so much. Dr. Simon has been recently named the Menopause Whisperer by the Washingtonian magazine. He's in private practice in DC and a professor at George Washington University. He is a tireless researcher, and what I respect so much about him is I got to spend a day with him in his office, and he is amazing with his patients. Dr. Becky Lynn is across from Dr. Simon here at the top, and Dr. Becky Lynn is an OBGYN like myself, and she has started a private practice called Evora Center for Menopause and Sexual Health in St. Louis. Becky is amazing and also a certified Becky, I don't want to get it wrong.
Yep.
Therapist. And I so respect her, and we're in this journey together in starting private practice. Dr. Cheryl Kingsburg is right below Becky, and Dr. Cheryl Kingsburg is a PhD and Chief of Behavioral Medicine at the University Hospitals in Cleveland Medical Center. She's a global expert on women's sexual health. I'm, again, thankful for all of you for joining, but Cheryl, I still respect how you are so knowledgeable. You find a gap and you figure out the answer. You're an incredible teacher, and I know you're a beloved therapist, so thank you. And Dr. Maria Sophocles, I got to meet you because you taught me how to do Mona Lisa Touch, which we're now offering at True Women's Health. And really, I love how you talk to your patients and take care of your patients and offer them informed consent about all options to treat how they might suffer from painful intercourse and consequences of menopause. So with that, I'd like to just start. And again, let's see where this conversation goes. Dr. Simon, would you share with us maybe a little bit about yourself if I didn't include what you wanted, and why do you do what you do, and give us some takeaways?
So first of all, I want to thank you for inviting me, and I really do appreciate the opportunity to basically share the podium with such fantastic colleagues who are able to carry on the torch that maybe some of us older, mostly guys actually, started. But it's really wonderful that you all are interested in women's sexual health, which has long been neglected by the healthcare community, regardless of what your training is. And I like to think about sex and menopause and aging and weight. Let's put our body weight in that same picture. They're all connected. I like to think of them in an evolutionary context. That is to say, why do we all do what we do? On some level or another, it's all about reproduction or hormones of reproduction. And with aging, particularly in women following menopause, there is no reproduction. And so Mother Nature really kind of left women out in the cold with no evolutionary understanding, their bodies don't understand what this new biology, as well as psychology, and Dr. Kingsburg can talk about it, that they're going through following the end of their menstrual cycles, et cetera. And so I've looked at that phenomenon and how food and weight and hormones and menopause all fit together in an evolutionary context to try and understand why we as a society have 2/3 of us that are overweight or obese, why couples that have been married or in relationships for long periods of time frequently have little or no sex, and why we have this concept that menopause and the hormones that were normal in premenopause are now dangerous and abnormal in postmenopause. And trying to attack all three of those in an individual's case, making it special for each woman or each couple. That's what I've been doing for the last 40 years or so. And it's been very rewarding for me because it all really fits together.
So why do you do what you do? Like what makes you do this every day?
Well, I think at the beginning, there was no one else doing it, or very few people that were doing it. And that meant that there were lots of women that were underserved. I think if you're asking a deep-seated psychological question, and I'll leave it to Dr. Kingsburg to see if she thinks it's really deep-seated, I think it's all because of my mother.
So talk about that. What did your mother experience that made you?
No, it had to do with having a very strong, absolutely brilliant mother who was a little bit of a tough love mom for me and my two sisters, and never took an answer at face value. And that's been my focus in terms of research, in not accepting at face value what a patient says, digging down deeper to understand the underlying biology, psychology, et cetera, of that. But I think it all goes back to my mom, who's no longer with us, but who I give a lot of credit for challenging me and my two sisters to always be better, to look below the surface,
Sure.
and to ask the really hard questions. And
Hey,
in
Jim, I'm going to interrupt.
the-
We just had a question from Kristen. She said, I'm 42. What should I be focused on for the next 5 to 10 years? To me, that sort of fits in with what you just said.
Yeah, this is a time after reproduction, typically, and a time when women begin to gain a lot of weight, and also a time when they're questioning their place in society, in their relationships, in their jobs, etc. It's an opportunity. You should see it as an opportunity to make those changes that True is trying to bring to them in terms of their whole life health, that each of us are trying to bring to our own practice, that Dr. Kingsburg is focused on people looking inside themselves and understanding what makes them tick and how they get into bad habits or get out of them. These are all fantastic to do, and now's the best time. Kids are grown up, kids are out of the house, you can focus on your relationship and yourself, and hopefully you have a little money to spend on yourself and for self-improvement.
Hey, Jim, it's not necessarily true that at 42 kids are going to be out of the house.
I thought
one thing that has changed, as you are a reproductive endocrinologist, is that we can help women have children at a variety of ages. So 42 might be you are an empty nester, but 42 could be that you have a toddler. So it's an interesting time, but your idea of taking care of your health for the next 40, 50 years really is key, regardless of who's in the house with you.
Exactly.
Yeah. I also think it's a time where you don't necessarily think you need to go to the doctor. Whereas when you're younger and you're having children, well, you're in the, obstetrician's office all the time. Somebody's always checking your blood pressure, checking in with you. And then in the 40s, well, maybe you show up once a year, and then maybe you hear that the PAP recommendations are that you don't need it every year, though you still do need to come once a year. So maybe you're not there to see the doctor when there's a lot of prevention that could be going on, and education about what's going to happen when your periods stop and your ovaries aren't making hormones. Because one of the things that I think is that we don't educate women on menopause.
They don't know what's coming, right? No. Like Maria, I've seen you talk to your patients about that. Like, people don't know what's coming, right?
No, and we can instill behaviors in our patients in their 40s that then will pay big dividends in their 50s, 60s, 70s. Regular exercise. They don't have to do aggressive exercise, but regular exercise. Cardiovascular health. We know there's a huge gender disparity between cardiovascular concern among doctors between women and men. If a 42-year-old has chest pain and goes to the ER, we know that she's treated differently than a man. So it's great for women in their 40s, even before menopause, to be thinking about maintaining their weight, self-care, emotional health. They dig in their 40s to raising their kids or taking care of their aging parents. And then they look up at 55 and say, I have 20 extra pounds and I'm depressed. How did that happen?
Yeah, like, what's going on? And I think it's so important for women to know their risk factors. For example, for mood disturbance, if they have postpartum depression or bad PMS as a 30-year-old or 40-year-old, they're at very high risk for having depression and anxiety during the menopause transition, Cheryl. Like, I would imagine you see a lot of that.
Well, I do, because I do see postpartum depression, and I also see perimenopausal depression. We know that depression rates are twice that of men, and they are twice that of women in general during the perimenopause. And we don't know the exact reason, but it makes perfect sense that hormonal shift, not necessarily the hormonal change permanently, but the shifting is what creates that mood disturbance. And too many women learn to live with it. They learn to live with the mood changes. They learn to live with the vasomotor symptoms, the hot flashes. Jim, you said women were left out in the cold. That's probably the only good reason we have hot flashes. And women don't know that, for example, genitourinary syndrome of menopause, vulvovaginal changes are related to menopause. And so they often go untreated, thinking it's either just a natural part of aging and have to learn to live with it, and or their clinician doesn't ask about it because they assume that if a patient doesn't bring it up, then they're not having a problem. So there is a communication gap.
I just wanted to seize on one thing that you said that is really important, and everybody on this call knows for a fact. Women in our culture, and our culture is not one thing, but women in our culture more generally frequently put themselves and their health and their needs last. Yeah. They put them behind their spouses or significant others. They put them on themselves on a lower level than their children, for sure. And there's always something that's more important in their own minds than taking care of themselves. But if they're not healthy, if mom's not healthy, or if she's not healthy, or she has problems, everything else falls apart. So exactly. I think all of us can agree that we want women to seize this moment to do some self-reflection and take care of themselves.
Exactly. And I think part of that is knowing your family history. Who had diabetes in the family, which puts you at risk for insulin resistance. And I know Becky's going to address that. Who had depression, anxiety, who had a heart attack, so it's so important that we know our family history at 42, and then we understand our risk factors. If we have high blood pressure of pregnancy, toxemia, preeclampsia, it makes us at very high risk for early heart disease in the perimenopause and early menopause. So it's so important that we know these things about ourselves and we take action before it's too late. Becky, do you want to talk a bit about why you do what you do? And I know one of your favorites, like me, is insulin resistance.
Yeah, so why I do what I do. So I, like you mentioned, just recently opened the Evora Center for Menopause and Sexual Health. And I am so excited about what I'm doing because in my practice, I really give women the time that they need, not just to come in, do your pap smear, send you on your way, but like you all, I think we all are like this. I'm about prevention and lifestyle changes, nutrition, diet, bone health, and I really give my patients time. So why do I love what I do? Because I can do that now. I'm in a situation with my new center that I have the time and I'm not, running behind. I have the time to sit and listen. And, you had mentioned that we would talk about like what it means to you and how you like this and what makes you enjoy it so much. One thing that I've noticed that I enjoy is I enjoy being a support person. I enjoy just listening, right? Like how in most practices, like you just don't have time to really listen. You got to solve the problem and move on. And I just like listening because people have issues and they want to talk about them. So I love what I do because I don't know, it just makes me so happy that I can do it how I want to do it.
Sure. No, I love that. And you've gotten more interested in supporting people in healthy weight lately. Like, tell me about that.
Yes. So, it's kind of interesting how I've always been sort of a calories in, calories out kind of person, exercise, diet. But I found
it's not that simple.
Oh gosh, no, it is not that simple. I found that many of my menopausal patients would come and say, I just can't lose the last 15, 20, 30 pounds. And I'm eating right and I'm eating healthy and nothing's working. So it kind of prompted me to dig a little deeper into weight management and how hormones play a role in your weight. And like you mentioned, you become insulin resistant when you're postmenopausal. So your body doesn't use insulin, or it doesn't put glucose into the cells like it used to. So your body pumps out a lot more insulin, and insulin makes you fat.
It pushes it straight to belly fat, right? That's what we get that
belly.
obesity.
I know, it's that beer belly or apple shape. And actually, if you deposit fat around your middle, it increases your risk for cardiovascular disease like heart attack. And I think we're not always aware of that. But there are things you can do. And even estrogen is linked to insulin resistance. So, we didn't go down the path of all the benefits of hormones, but that's a benefit of estrogen.
Well, I love the KEEPS trial, right? The KEEPS trial talks about women who take estrogen, they have a lower risk of insulin resistance measured by HOMA-IR, right? Mm-hmm. And they have less central obesity over time, and one could extrapolate a lower chance of diabetes.
Right. And yep, absolutely. So I've found a lot of joy in helping people get to their goal weight.
And we have so much available to us now.
Maria?
I was going to say there's so many more resources available to us. When I trained in the 90s, we didn't even bother to discuss this. We just told women to eat less and exercise. And it was such an empty promise that we were holding out. Right. And then we have actually apps that have real life coaches, Noom and things like that. And we have medications that are now safe and effective that really target specific substances in the brain for satiety that can help train women to eat less. I think we have a lot more at our disposal. So sort of shame on us if we don't tackle that, whether it's doing it ourselves like that is, or referring to a center that can give the time and expertise.
Right. Well, one thing I've really learned from Cheryl is, the whole concept of motivational interviewing and really helping people get attached to a goal, but also really helping them understand why. Why are they gaining weight? Why does a woman of Asian descent have prediabetes at 5 pounds overweight, right? Genetically, she's more insulin resistant. So Cheryl, I'm just so grateful that I've really seen you talk a lot about really helping people understand why they want to and then what to do.
Sure. Well, yes, you have seen me talk a lot because I talk a lot, but but like Becky, I was trained to listen. But when it comes to behavior change, it's a very easy thing for clinicians to say, do this, but they don't really always know how to help the patient get there. So in my practice, back to why I do what I do, I'm a psychologist in an OBGYN department. So I do behavioral medicine. I look at the psychological aspects of medical conditions for the most part. And so since I'm an OBGYN, it's mostly women's health. So menopause is one thing, sexual dysfunction is another, perinatal mood disorders, but helping them understand how to make those changes, which really is a cognitive shift. They need to have the motivation to do that. And sometimes you need the behavior change first. So I see also bariatric surgery evaluations because they need a psychological clearance before they actually have surgery, talk about new things coming up. And so many of them, have this sense that the surgery will do the work for them. And while it will help them lose initially, they need the behavior change and the cognitive shift in how to keep a healthy diet, how to eat healthy, how to exercise. And that's the key to maintaining the weight loss. Right. And when you talk about motivation, here's the secret to exercise. Do not rely on motivation. Unlike Becky, who actually likes it, unlike her who likes to exercise, I do not. And so I know that for most of my patients, they will never be motivated. So we need to put it in as a habit and a behavior, and they never get to ask, do I feel like it? Because I tell you, the day that I ask myself, do I feel like exercising, is the day I will never exercise again for the rest of my life.
But I know you exercise every day, so it's right?
I don't like it. But it's helpful to validate that for patients so that they don't think there's something wrong with them and they learn the skill. So if they're like Becky and enjoy it, then we find ways for them to be motivated. If they're like me and it's a chore, then we help them work through that. It is an individualized process, just like managing menopause is individualized for each woman who comes in.
So Cheryl, actually on that note, we have a nutritionist who works with us, but I am in the process of looking for a behavioral therapist, because one thing I've learned is that, we need to learn those skills to get past bad eating habits. And it's not a sign of weakness if you walk by a piece of cake and eat it. It doesn't mean you're a bad person. And I've, read about how behavioral therapists can really teach you skills like you're doing to handle those situations. So if you know anybody in here, let me know.
Here's one of the only benefits of COVID-19 is that telehealth has really taken hold.
Yes.
And one of the things that's happening is that there will be reciprocity across state lines, including Missouri, that will allow you to send your patients to me.
Perfect. Look forward to it.
Yes. I will absolutely do that.
Exactly.
There we go.
Cheryl, to piggyback on something you just said, Maria, you and I have talked about how many women suffer in silence because of painful sex after menopause. And again, you've taught me the tool Mona Lisa Touch. Do you want to talk a bit about why you do one of the many things that you do in terms of helping women with this?
Sure. I sort of like we've said earlier tonight, there's a lot of sort of shame and stigma about menopause and misunderstanding that painful sex means something's wrong with you and you're broken, or it must be your fault, and that it's not even linked to menopause. I can't tell you how many women come to my office and say, well, I have this problem, but it's not menopausal, that's hot flashes. And even though we put our teenagers through all kinds of courses to learn about puberty, we don't have anything like that for menopause. I have couples who come to me and the husband says, I really love her, but there's something broken with her. And it's because they don't understand that the loss of the health of vaginal tissue, the loss of the integrity of the collagen, and the lack of blood vessels is a natural consequence of a loss of estrogen that comes from reduced ovarian function. Basic to all of us, completely unknown to most women and to many non-GYN clinicians, many. Combine that with the shame of talking about sex, not only from patients, but from doctors. We know that 80-something% of doctors don't bring up sexual questions while they talk to a patient. So you get a lot of women who have genitourinary syndrome of menopause, or in the common parlance, vaginal atrophy, painful sex, and don't even realize A, it's treatable, and B, that it can be treated safely and easily.
Right.
I guess my aha moment, or my reason for adopting the Mona Lisa Touch, which is just a CO2 laser. CO2 lasers have been used since 1964 in America, but why I use it in the vagina is that so many women still have such a stigma about using estrogen. They still view it as a dirty word. So you, like all of us, we can show them the safety data. We can give the most heartfelt understanding explanation to them about how vaginal estrogen is safe and it does not carry risks of heart disease, stroke, or cancer, and they will still go home and not fill that prescription. And so I felt that by bringing laser to the United States in 2015, that this would provide another opportunity, a medication-free opportunity to regenerate vaginal tissue. It's not perfect. Nothing's perfect. I do believe it's extremely safe, and I believe it's effective. Sometimes we have to combine it with estrogens or ospemifene or DHEA, but I think it's a nice tool that we have. It's also nice for vulvar disease. A lot of women don't even understand that the itching that they feel, debilitating itching, can be something called lichen sclerosis. It's like this dirty secret. And we use steroids successfully to treat it, but same thing, a lot of women feel that steroids topically are somehow dangerous, or that they'll grow muscles or beards or something. So the long-term use is not great. So it's nice to have another tool. But I share what everyone here said, that it's important to have individualized care, like True is offering, and I think like we all try to offer in our practices, where we can customize what's right for each woman. And the best way to do that is just to listen. They'll tell you. Patients will tell you what's important, and they'll tell you what's most important. And then we can go
that goes to the idea of shared decision making. And while lasers are potentially an important option, and we need some long-term data, and perhaps priming the tissue with some of those hormones might be important for them to use. I think that, for example, the North American Menopause Society, and I'm a past president and Jim's a past president, really has been trying to promote in advocacy, their advocacy here at the moment, the idea of removing that boxed warning about local topical estrogen and hormones, because it is safe, and so it gives women undue fear.
Yes.
Even some breast cancer survivors, that they shouldn't be using something that is so essential, and the consequences and the medical consequences of not treating are not benign.
No, and
so I think
the healthcare system of not treating the vagina, and what the consequences are alone for the urinary tract. This is also a complete mystery to many clinicians and lay people alike, where they say, I don't understand, I'm having recurrent urinary tract infections, and you want to help me with vaginal estrogen. It's hard for people to connect those dots. And then if they see a box warning talking about cancer, there's very little chance they even understand why you're suggesting vaginal.
Exactly. Sometimes what I'll do is actually pull out that piece of paper and show people. I don't want you to get home and read this and think I'm lying to you. This is based on an old study. It doesn't apply. And Jim, you were president of NAMS when that came out, as I recall. That must have been a challenge.
Don't
there's
blame
been
me,
lots
though.
of questions on the side.
I didn't do it.
Exactly. There's been a lot of questions on the side from internal medicine colleagues who are watching, as well as women out there, about hormone replacement therapy. What would you offer as a couple takeaways tonight for women to consider about HRT, one of our favorite topics?
So it's, Becky, I just don't think it's that complicated. The Menopause Society's put together a very nice app to help non-experts decide on the risk benefit for a particular individual. It's evidence-based, and it doesn't have to be, there you go. It just doesn't have to be that complicated. I know everybody on this call sees the complicated patients, but for the average patient, it's fear and shame that are bad and that are preventing women from really getting good care, which is available.
Right. And what I was going to say is that, I was in training when the Women's Health Initiative study came out, which really gave hormones a very bad name. And for those who don't know, that was a big study that looked at only one type of hormones and found that if you looked at all of the women, there was an increased risk of breast cancer, blood clot, heart attack, and stroke. And it got a ton of media attention, and that's what scared everybody off their hormones. But over time, they looked at the data by age group and found that women between the ages of 50 and 59, or within 10 years from their last menstrual period, actually had a decreased risk for heart disease. And all of us are afraid of breast cancer, but the number one killer of women is heart disease. And so, Jim, I'm going to steal from you your zombie idea. I tell that to all of my patients, and I put it in my presentation.
I love it.
The idea that hormones are all bad is a zombie idea. It just won't die. Thank you to Dr. Feynman for that. But I do spend a lot of time talking about in the right woman and also the shared decision making. Here are the risks, here are the benefits. Are you in that age group where you could really see a benefit? And it's not just cardiovascular disease. It keeps your bones strong. It keeps your skin soft. It helps with your sexual function, your urinary tract. So I feel like I spend a lot of time trying to get the reputation of hormones out of the mud, because there really is a role for hormones, and they do so much more than just treat hot flashes.
I love that. And I love how when patients come in and they're suffering, not just the hot flashes and night sweats, but potentially it's the sleepless nights, it's the fatigue, it's the, and hormones are FDA approved to treat hot flashes, treat vaginal dryness, GSM, to prevent osteoporosis, but off-label, we know that they affect women's quality of lives in terms of their ability to interact and be successful. And there's safe ways to provide these hormone replacement therapy, options. And I'm just so grateful that I live in a time where we have really good data. Someone asked a question on the side about bioidentical. Cheryl, I know that's one of your favorite topics. You want to talk about bioidentical and what that word means? All of us here are laughing because we know that that's such a topic.
Well, and also because NAMS has come out with a statement against using bioidenticals. So that's also, a zombie idea, I guess. It just won't die, that bioidenticals are somehow safer and more natural. And the term bioidentical is kind of nonsensical, because the idea is replacing a hormone that you make in your own body, so in particular estrogen and progesterone. And compounding pharmacies have done a marvelous, job in marketing the idea that their version of compounded hormones are somehow more natural. They call them bioidenticals, and they sell them to women. They say this is individualized, but in actuality, often don't even know what you're getting or how much you're getting. They are not necessarily FDA approved. And so there are actually bioidentical FDA approved hormones that are on the market, and any of the hormones that are produced in a lab, if you will, are as safe and effective as anything that would be called bioidentical, and they have regulatory specificity behind them and safety.
I always say consistency, in terms of compounded hormones, we don't know what people are going to get from batch to batch. And especially, the pellet therapy, I just can't stand that, because again, the people who are providing pellet therapy, I don't believe that they're giving informed consent. And women come in and their levels are just all over the board and just crazy high, especially with testosterone pellets that are just not okay, not safe. And again, I believe that the one of the things that we're going to do to change healthcare and make it better is we put the information in the hands of women and we encourage them to ask the tough questions.
Right. There's not long-term safety data on the testosterone in any form. So.
But Dr. Simon has taught me how to use FDA-approved testosterone, FDA-approved in men, but women. And here we have several pharmacies who will break up a box of 30. Men use one packet a day when their testosterone is low. For women, we ask them to squeeze out 2 to 4 drops a day of the packet and can use an FDA-approved medication in a safe, off-label way. And it's only, locally, it's only $20 a packet. So $20 for about 5 weeks. We can use bioidentical, again, I hate the word, but bioequivalent FDA-approved testosterone in women for low libido, for bone health. Jim, do you want to talk about that a minute?
Yeah, so just very, very briefly, both Dr. Kingsburg and I are past presidents not only of NAMS, but also of the International Society for the Study of Women's Sexual Health, or ISWISH. And Dr. Lynn is very active. She can talk about her involvement in that organization as well as our other members of this panel. But ISWISH is about to publish, it should be available in several journals all at the same time. These are scientific journals for any of the clinicians who are listening. A how to safely give testosterone to postmenopausal women using FDA approved or other products, which we, this international group of experts, felt to be acceptable, safe, and with documented efficacy. So that's coming within the next 3 months for everybody who's willing to read it. And it'll be published in a medical journal, a women's medical journal for internists and primary care docs, in the Journal of Sexual Medicine, which is our primary journal for ISWISH, and in a menopause journal for menopause practitioners. So all of that's coming, and it's long overdue, but I thought it was necessary.
I love it. And
hey, Jim, wait, can I just want to point out, though, that I'm not sure that you said it, but the data are, and there's also a global consensus paper that came out last year that Jim and I were authors on from many societies, that this is about hypoactive sexual desire disorder, that the data, and there are good data to support this, are clear that testosterone is useful and effective in the treatment of hypoactive sexual desire disorder. We have no clear long-term evidence about its use for other conditions, but we do know that it is for the treatment of hypoactive sexual desire disorder. So I just wanted to specify what we use it for.
No, I appreciate that, Cheryl, because I was even hesitating to say bone mass, right? We know, data in men, and again, you guys are more the experts in terms of the authors of the study than I am, but, again, we can safely say it does treat hypoactive sexual desire disorder, but
in menopausal women, not in premenopausal women.
Well, correct.
You
This
want
is
to make
what
that distinction because it's
important
for everybody who doesn't know that. It's for postmenopausal women.
exactly.
Peri in the 40s, yes.
Well, the assumption is that we know that menopause decline, with menopause, your testosterone levels are declining. So the assumption would be that a premenopausal woman essentially has, enough testosterone, and it would be a postmenopausal woman, if she has HSDD, that would be at risk for or might benefit from testosterone. There are some premenopausal women who might, but we have other treatments that are actually FDA approved for premenopausal women. At this moment, the FDA seems to think that premenopausal women are different than postmenopausal women, and so the treatments for HSDD that are approved are only approved in premenopausal women.
So we're talking a lot about HSDD, or hypoactive sexual desire disorder. And Cheryl, I love how you've talked about this at national meetings. You talk about women who just feel like that switch has been turned off. And I remember coming back from one of those meetings after I heard you talk, and I had a patient, and I talked to her about this, and she just cried with relief. She said, I thought I was broken, and her relationship was good. She loved her husband. She thought he was really cute. They'd had really good sex in the past. Her hormones were fine. She was still having periods. There was no other reason for her to have low desire. And when I talked about the switch, again, she just cried. Yeah. So, if you want to talk about that a bit more and a little bit about the treatments.
It's very similar to we were just talking about genitourinary syndrome of menopause, that women don't know that these are common problems. And so most of the women that come into your office, and certainly in mine, think that they are the only one that has had this problem because we don't talk about it. It's too closeted. We don't talk about sexual dysfunction. Until Viagra came out, we didn't really talk about erectile dysfunction in men, and now it's everyday occurrence and it's on television. But we don't really talk about hypoactive sexual desire disorder. It is the most common sexual dysfunction for women, affecting about 1 in 10. So of all the women out there watching, 1 in 10 of them are saying, I thought I was the only one. And it is the persistent loss of essentially the appetite for wanting. It's wanting to want sex. It's not whether you have it, because most of the women who are in relationships, even if they've lost their desire, are having sex with their partners for obligation or mercy sex or to maintain the relationship. And it's not necessarily that they're, hating it. They just have no appetite for it. It's like walking into your favorite restaurant, no matter how much you want to feel hungry, you have no appetite. And so for women, that's really distressing to them. We think about depression as the loss of interest in things that bring you pleasure. When we think about HSDD, it's the loss of interest in sex. And that's a very distressing thing because for most of us, sex is important, and it's the anticipation of it. It is the joy of it that gives us meaning and color in our lives. And so women are really distressed. They don't know that it's a medical condition, because if they do actually bring it up with their healthcare provider, they're usually told, oh, just go on a tropical vacation or have a glass of wine or, get a new partner, or it's all in your head. And so they don't recognize that while it could be, if you have a bad relationship, that's not HSDD, that's a bad relationship. If you're stressed because you've got, you're worried about COVID or you're about to lose your job, that's not HSDD. If it is persistent, despite everything else going okay, and you have no appetite, no hunger, no anticipation, that is a medical condition. And for that, we have some treatments. And so women should feel empowered to go to their healthcare provider and say, this is a problem for me. Because if your provider doesn't know what to do about it or tells you, oh, honey, go have a glass of wine, get a new provider. And now that we have telehealth, you can probably find one of us, even if we're not in your city.
Exactly. That's been one of the benefits of COVID, is that we have telehealth and we can send our patients. And again, it's, one thing is for women to go to menopause.org and find a certified menopause practitioner. Yep. And that certified menopause practitioner, even if he or she doesn't specialize in sexual health, they generally will know someone in that area who does. And more, we have to use this network of providers. And I know ISHWISH is developing a network of providers to find someone who is involved with ISHWISH in their area. And more, we've got to help women, again, that grassroots swell to get more and more people to talk about it.
And the other resource is AASECT, the American Academy of Sex Education Counselors and Therapists, because sometimes they don't need a physician as much as they need a sex education counselor or therapist, a sex therapist, who they can discuss the relationship with or their relationship with sex with. So many women feel so much shame about sex itself. And, I don't know whether it all comes from their mother or from Catholic school or where it comes from, but we all bring baggage with us to our sexual lives. And so don't underestimate the power of a good counselor and therapist to be able to flush all of that out. Because while we have FDA approved medications for HSDD, that there's no way that Band-Aid fits for everybody. And so I think AASECT would be a great resource for people.
One thing we really haven't talked about that I just love about my practice is being able to know about pelvic floor physical therapy. So for example, so many women will have pain with intercourse because of pelvic floor, essentially spasm, or maybe they've had a shortening of the vagina from radiation, from anal cancer, or surgery, or chronic endometriosis with stiffening of the pelvic tissues. And there's that pain that happens. And then as Cheryl talks about, that anticipatory pain, the tightening of the muscles, it's so important that we can teach women, to teach their muscles not to be scared. It's not in their head, it's in their pelvic muscles. And, just today at the clinic, we talked a lot about it. And over the week, I think several patients have left with a milli dilator. A milli dilator is something that goes in the vagina and it expands with a touch of a button on the handle, thanks to Dr. Krishman, who invented this. But that this, or Kreishman, sorry, but this Millie dilator, it's like a patient having a physical therapist in their home, where women can use this dilator 10 minutes every day to teach those muscles to not be scared. And I know this is something we all, have in common, that we know about this. I work with pelvic floor physical therapists. I'm sure you all do. Does anyone want to talk about how they incorporate this in their practice?
So I send my patients to pelvic floor physical therapy so often for so many reasons. I see a lot of women with endometriosis, and maybe they've had their surgery, they've been treated, they've had the endo removed, but they're still having pain, and everything else is normal. But it's really important in those instances to realize that pain, whether it's due to endometriosis or interstitial cystitis or bladder pain syndrome or even irritable bowel syndrome, anything that's causing pain in the pelvis can make those muscles around the vagina contract. And then your pain's not going to get better unless you treat all of the contributing factors. So that's where I think it's very important to work with a variety of practitioners, right? So an endometriosis surgeon or a MIG surgeon, a pelvic pain specialist, a sexual medicine specialist, and definitely pelvic floor physical therapy. One thing I will say is a lot of times my patients are very hesitant because they think, oh, that's weird, a physical therapist for the vagina. And so on my YouTube channel, I have a couple of videos where I speak with some of the physical therapists that just go through what to expect when they get there. What's it going to be like? What are the sort of things that pelvic floor PT can treat? And it can treat so many different things. So I have to sing the praises of every pelvic floor physical therapist I've worked with.
Totally agree. Jim?
I totally agree also, and I've been using pelvic floor physical therapists in our area for many, many years, but not all of them are equally skilled at, nor are we, into taking care of women with pelvic floor dysfunction, whether it's the muscles are too tight, which is typically where we see our patients' problems, or the pelvic muscles are too loose, or they're associated with some kind of injury, hip injury, spine injury, etc. It's really important that whoever's referring, and the people on this call, we know who the good people are in our areas, but not everyone is equally skilled, and not every area of the country has a skilled person who's on an insurance plan. So it really requires a little homework. And in the same way that I know that Dr. Kingsburg would agree, not everybody can connect with a psychologist in the way that they can develop, or any of us, quite frankly, but in a way that they can develop a good therapeutic relationship. Same thing happens with pelvic floor physical therapists. If the patient doesn't feel comfortable, if the physical therapist can't make that connection, got to be able to find a different one.
Agree. You know what I'd love you all to speak to, I just thought of this, tell me what you think, is, in a couple years from now, let's say 2 years from now, what would you want changed about our healthcare system? What would you want our patients, women out there, to see differently about our healthcare system? I want us to think bigger about what is possible. Jim, you were talking, you want to go on that one first?
Yeah, so I'd like to see an FDA that's more focused on women's health generally, that's more open to the abundance of literature in women's health, and not focused on a particular fear that the men and women at FDA have in their own heads, but really is a little more, their view is a little more expansive. And the other thing I'd like to see is better payment for women and men on Medicare who tend to get short shrift because reimbursement is so poor to those practitioners, regardless of what type, whether they're primary care docs or obstetrician gynecologists or any of the specialists on this call. Medicare just doesn't pay well enough for many women's problems to be taken seriously by their practitioners. And I'd like to see those reimbursement rates come up to where older women's specifically problems are seen as having value.
I love that. Cheryl, what do you want to see?
I would like to see much better training of clinicians in women's health issues, in particular in sexual function and in menopause. I think medical students are not given enough training. I think residents in primary care and OBGYN, unfortunately, are not given training, and they are the ones. Nurse practitioners have caught up, and they are really, running away with the women's health boat here. But physicians in particular need to be, and what I want is in the EMR, the electronic medical record, when a physician asks the basic questions, that sexual health is covered and that it is a required, topic to be covered, so that physicians can't get away with not asking, so that women can get their women's health needs addressed, which means that sexual health is as relevant to their health and quality of life as anything else.
I agree. And I think part of it, to your point, is the training is important. Those questions often are on the questionnaire, but the doctor, it was me 10 years ago, wouldn't answer those questions or address them because I didn't know what to say. So us doctors, us healthcare providers, us PhDs, we like to fix stuff. And if we can't fix it, we don't want to hear about it, right? So we have to train providers to know the answer so they feel comfortable.
And
if it's in their required, it's in their requirement for their reimbursement and for their medical record, they will have to do it. It's sort of like if it's on the test, they'll learn it.
And then maybe they'll look up Ishwish and they'll get education from the flow chart that you've spent so much time developing. I love it. Good.
An extension of that is cultural competency as well. And we're living in a world where in our country, there is a more heterogeneous population in terms of cultural background and also in terms of sexual identity. We have to train clinicians who understand the subtleties of caring for bisexual women, homosexual women, transgender patients. I work closely with a transgender surgeon, and it's shameful to hear how many of the transgender patients have been actually excused from their OBGYN practice because they were told their OBGYN doesn't treat that disease, and so we need clinicians who are more culturally competent and have comfort and training and education about gender identity and fluidity. So
exactly, and just even cultural, right? In terms of women of different cultures, there's so much that goes into how women perceive their sexuality and how relationships evolve from the cultural sense. And it's so important that we all know that.
Right. So just bouncing off what Cheryl said, I also think that the future of women's health, I mean, of course, at a ground level, it involves training and training nurse practitioners as well. But at a different level is looking at the biotech sector, which look how biotech has taken the reins from the government, really, for COVID and development of a vaccine. There is a sector within biotech called femtech, which is biotech not only for women's health products, but with female CEOs and female dominated boards. And we know that in the tech sector, females are poorly represented, but in femtech, they're really striving to have women involved from the boardroom to the research lab to sales to making decisions about what's needed. And I think that if biotech can pivot and gain momentum in the feminine femtech version of itself, I think this will drive development of products that really women want and need.
Well, also, if we could get more OBGYNs on the FDA, maybe that would help.
Yeah.
Certainly another hope, but even the cost, Jim was mentioning the cost. Premarin was launched in 1946. So the fact that some of my patients still pay $300 for a prescription medication that long since paid for its R&D. I mean, you're telling me you have to pay $300 for something that was invented in 1946? That's wrong. Something's wrong about that.
Exactly. And then the husband gets Viagra and the wife is like, well, why didn't I get asked before he got Viagra? Now he has Viagra, his parts work, and I have pain, but my prescription costs $300 and insurance will pay for it, and it pays for the Viagra.
Right. It's another
That's just cruel.
example of gender discrepancy
Right.
that wreaks havoc in the bedroom,
Exactly. Becky, what do you want to see happen in women's healthcare?
I have two things. One is that I really think we need to focus more on prevention. I think for most clinicians, time is a huge barrier. So I really think it's important that, whatever healthcare organization you work for, that they give you the time that you need with your patients to not just address problems, but to address the whole person and prevention. I think part of the reason we don't spend a lot of time on prevention is because clinicians don't have time. The second thing that I think doesn't pertain just to women, but to everybody, and I think COVID has really driven this home, we all need healthcare. I firmly believe it's a right. There's no reason why in a country as wealthy as ours, there are people out there who don't have healthcare or who go bankrupt because they have hospital bills. I can't believe that we have that kind of system here in a wealthy country like the United States. And I really hope COVID has brought that home.
I remember a couple years ago, I proposed a preventative health program for women aged 40 to 55 to a local insurance company. And it was, everyone in the meeting thought it was great. It was turned down because the return on investment wouldn't be great enough because they don't spend enough money on women 40 to 55. They wouldn't see any change in their bottom line in the next 3 to 5 years. And I'm like, well, what about if we can lower the risk for heart disease in women who are 50? They're going to be less likely to have a heart attack when they're 70, and their quality of life is better and their engagement is better. Well, that didn't matter because it's about the bottom line today.
Right.
So, it's really driving that. And I so believe in risk stratification. If women know they have a higher risk for breast cancer, we can screen earlier and we can catch it earlier. If women know they have a higher risk for heart disease, we can screen it earlier, catch it earlier. Women don't want to be tired. They don't want to have a heart attack. They don't want to have cancer. It's I'm so sick of other, providers maybe saying, well, some women just don't care. Bull. Women care. It's our job to figure out what they care about. And one thing we have at True is I've developed an app. We actually made Yahoo News 2 weeks ago, the first app in the country, in the globe, that attaches menopause and wellness and overall risk stratification for heart disease, activity, cancer, diabetes, coping, all of these aspects together in health, because women deserve to know. And they care about something. It's our job to figure out what they care about. Right, Cheryl? And attach it. I see you nodding. And just attach actions to what they care about. It's what they care about, not what we care about as their practitioner, right? So,
right. Excellent.
Well, congratulations on the app.
Thank you. I'm very proud of it, and I can't wait. We're getting the bugs worked out with our patients. We're learning every day, and I can't wait until we can scale the app and more people can use it. It's just been fantastic. When you speak of True Women app, it's the True Women app. And what I love, Becky, you talk about time. In the app, I read what the patients have put into the app before. What is their goal for their health? And how do they think about food? How do they think about activity? What are their barriers? And then what we do at True is really, really help them solve for barriers. They have foot pain. Let's get functional physical therapy involved, whatever it is. So I really want to see more and more that all women know their stage of ovarian function. They know, are they in perimenopause? They know what to expect. Are they in menopause? They know what to expect. Mm-hmm. Women deserve to know all of this information. It's not a state secret. It is not rocket science. Mm-hmm. Women deserve to know, and they're smart, and they want to know, and then they can be empowered to live the life they want to live. So it's time.
Well, we're kind of preaching to the choir, because if they're on this chat, then they're already smart enough to know. Exactly. We now need for all of them to reach out to all of their friends who weren't on tonight and get them a little knowledge.
And share it. And also, I've shared it with the residents at Michigan State and Spectrum Health, and I believe you guys have all done that as well. But the more and more that we start this conversation nationally, is just, and again, I cannot thank you all enough. I respect you so much. I know, Maria, you're coming to Grand Rapids in August. Is that still going to happen?
Yeah.
And then this fall, I'd love to have all of you come and we can do an event together in person where we'll see where we are with pandemic and all of that. But I think the more we work together, this takes a village with all of our skill sets, with all of our expertise to really support women in total. So in the last couple seconds, anyone else have anything to add?
When is the app available for use? Can we use it? Can we spread the word?
Not quite yet. It's for use right now for patients who join True. Now, patients can join True even if they don't live in West Michigan and Grand Rapids. We can do telehealth, so it's truewomenshealth.com. I did 2 telehealth visits today, one in Canada and one in California. So it's like we can do telehealth visits, but also people can use the app once they join True. And, hopefully in the near future, we'll be able to scale that app and other people can use it. So thanks for asking.
Great. Thank you. Thank you for including us.
Oh, thank you.
I'm honored that you would. And so we're at an hour. If anybody out there in the audience listening has questions, please feel free to continue to ask those questions. We will monitor this and we will definitely answer in how we can. So all of you, please keep doing your good work. Please keep spreading the word. And let me know how I can join in your area. We can all work together to improve women's health.
Thank you, Diana.
Thank you.
Thanks, Diana.
Everyone have a good
Pleasure.
one. Thank you.
Too.